Everyone, today we'll be discussing hemochromatosis. Hemochromatosis is a disorder that is associated with deposition of excess iron that causes multiple organ dysfunction. Normally, iron absorption is tightly regulated because the body is incapable of excreting excess iron. Hemochromatosis has also been called bronze diabetes due to the discoloration of the skin and associated disease of the pancreas. When we talk about the etiology of hemochromatosis, so usually what happens is retained iron is primarily deposited in the parenchymal cells in hereditary hemochromatosis, whereas in the case of transfusional hemochromatosis, it is primarily deposited in the reticular endothelial cells. The excess iron that is deposited in the cells is known as hemosiderin. This leads to cell death and replacement of these cells by a fibrous deposition that causes destruction or impairment of organ function. Hereditary hemochromatosis occurs in homozygotes with a mutation of the hemochromatosis gene, which is the HFE protein on chromosome 6. So basically what they think is what causes the damage is hemosiderin, okay? Hemosiderin is what leads to cell death, and when this cell death, there is replacement of the cells by fibrous deposition. So when this fibrous deposition, that's what leads to organ dysfunction. When we talk about clinical features, so we need to know the common organs affected by hemochromatosis include the liver, the pancreas, the heart, thyroid, joints, skin, gonads, and the pituitary gland. Diabetes is the primary manifestation of pancreatic iron deposition. Arthropathy manifests as joint pain without joint destruction. Cardiac symptoms result from iron deposition in the cardiac muscle fibers and cells of the conduction system. Hypogonadism with resultant impotence is due to iron-induced hypothalamic or pituitary failure, resulting in impairment of gonadotropin hormone release. Skin hypopigmentation arises as a result of both iron and melanin deposition. Iron overload of macrophages can cause impaired phagocytosis and lead to decreased immunity, resulting in an increased risk of infection. Iron deposition in the thyroid gland causes hypothyroidism. The iron overload that causes hemochromatosis can occur in 3 ways. So how do you get the iron overload that causes hemochromatosis? So it's in 3 ways. 1, if there's a massive oral intake of iron, that's 1. 2, there's increased iron absorption. So basically the iron intake is normal, but the absorption is way higher than what it's supposed to be. Or excessive production or massive transfusion of red blood cells, because we know in our red blood cells we also have iron, right? The most common cause of hemochromatosis is an inherited autosomal recessive condition with variable penetrance. This condition is classified as primary hemochromatosis. Hereditary hemochromatosis occurs in homozygotes with a mutation of the HFE protein. So when we talk about the pathophysiology, the types of hemochromatosis which we're not going to discuss in this video. So the enterocytes, which is the cells in the intestines, they are going to absorb iron, okay, increased iron absorption. So what that will do is that's going to lead to a reduction in circulating hepcidin. So when there is a reduction in hepcidin, so the macrophages are going to be activated and lead to an increase in iron release. So that will lead to an increase in serum iron and increase in plasma iron concentration. So causes of secondary hemochromatosis include erythropoietic hemochromatosis, a condition that results from the absorption of excess iron because the patient is producing excessive amounts of red blood cells. This often occurs as a result of an underlying disease of the red blood cells that causes them to be more fragile and therefore to have a shortened lifespan. When the cells are destroyed, the iron from them is deposited in the body tissues. On history and physical examination, so patients are usually asymptomatic until adulthood, and often a diagnosis will not be made until multiple systems are affected. Symptoms are related to the organ affected, but almost all patients are going to complain of severe fatigue. Women with hemochromatosis become symptomatic even later in life than men due to the physiological blood loss that occurs during menstruation. Late manifestation occur when iron starts getting deposited in the tissue progressively. So other features that you will be able to notice will be koilonychia, secondary diabetes, discoloration of the skin, which is diffuse hyperpigmentation, arthropathy. When there is liver involvement, you may or may not notice jaundice. However, what you will notice is the liver function tests will be abnormal. Cardiac involvement, so this can lead to restrictive or dilated cardiomyopathy, arrhythmias, and cardiac failure. Endocrine dysfunction, they can present with diabetes mellitus, pituitary hypogonadism, hypopituitarism, thyroid dysfunction, adrenal dysfunction, parathyroid defects, and osteoporosis. Infections, patients with iron overload are at increased risk of infection from Yersinia enterocolitica, Listeria monocytogenes, and Vibrio vulnificus. When you want to evaluate a patient suspected of having hemochromatosis, you check for serum transferrin saturation or serum ferritin concentration. So ferritin level above 200 mcg per liter in women or 300 mcg per liter in men, or transferrin saturation of more than 40% in women or 50% in men should lead to further testing. Radiography can also be utilized, such as a chest X-ray where you can note cardiomegaly and increased pulmonary vascular markings. MRI of the liver is a non-invasive way to measure liver iron content. Liver biopsy is the test that is most sensitive and specific for measuring liver iron content, and it can also assess liver damage. On histopathological analysis, if you do it with pulse Prussian blue staining, you will notice a classic pattern in which iron deposits primarily in the hepatocytes and biliary epithelial cells, with slight involvement of the Kupffer cells. So we don't do a liver biopsy in all the cases, so there are certain cases in which it is indicated. So 1. Elevated liver enzyme in a diagnosed case of hemochromatosis, serum ferritin levels of more than 1000 mcg per liter, or liver enzymes usually elevated, with most patients having elevated aminotransferase levels. However, what you need to note is the liver enzymes are usually not higher than twice the normal levels. Fasting blood glucose levels need to be checked for diabetes. Other tests that need to be done in patients with high ferritin levels are echocardiogram for cardiomyopathy, hormone levels to evaluate hypogonadism, and bone densitometry to evaluate for osteoporosis. Management. So the conventional therapy for primary hemochromatosis is phlebotomy, basically making a patient bleed. So patient may require 50 to 100 phlebotomies of 500 ml each to reduce iron levels to normal. So the phlebotomy usually is preferred to be done once or twice a week. Once iron levels have normalized, lifelong but less frequent phlebotomy is advised, so such as maybe doing one phlebotomy every 3 months. So that is roughly 3 to 4 times a year. Pre-existing end organ damage is rarely reversed by phlebotomy. So treatment for end organ dysfunction such as insulin for pancreatic dysfunction is indicated, basically symptomatic management. If hemochromatosis is detected early, treatment prevents end organ dysfunction, and there is little mortality or morbidity associated with it. Desferoxamine is an intravenous iron chelating agent. Diferipron and deferasirox are oral iron chelators. Erythropoietin in combination with phlebotomy is sometimes administered to maintain the hemoglobin concentration while forcing iron mobilization. Patients who have end-stage liver disease may be candidates for liver transplantation. Prognosis. So if hemochromatosis is left untreated, it can lead to progressive damage of the liver. and lead to cirrhosis, hepatocellular carcinoma, and other complications associated with iron overload in the tissues and organs. With advances in diagnosis and management of this condition, the prognosis has improved in the last few decades. Hepatic fibrosis or liver cirrhosis is the main prognostic indicator at the time of diagnosis. So early diagnosis and regular treatment with phlebotomy can decrease most of the complications associated with hemochromatosis. Complications. So patients are more likely to develop liver cirrhosis in the presence of additional factors like alcoholism or hepatitis. Other complications seen are hepatocellular carcinoma, diabetes mellitus, congestive cardiac failure, hypogonadism, osteoporosis. Patients with iron overload at increased risk of infection from Yersinia, Listeria, and Vibrio vulnificus. So that's all about hemochromatosis. If you like the video, please like, subscribe, and comment. Thank you.